folks. Kate or Julie, Kathy Bowers is trying to call my cell, which probably means she's trying to get in. Can you guys reach out to her, Kathy Bowers?
I'll do my best.
Howdy, everybody. I am trying to, oh, I got it to work. Yay. Okay. All right. So I'm looking at the actual, what do you call that? Theater? No. I can see every
gallery view. Gallery view.
Thank you. Thank you. Gallery view. Okay. I'm in the car again, guys. I'm struggling with this, so I'm trying to make it work. So, all righty. Well, first of all, thank you, everybody, for being here. As you know, this is the Guardian Peer Group, and this is one of the many programs that AGED created, sponsors, supports, so that guardians have lots of support. One of the things is trying to make sure you've got training that is very targeted for what you need, and speakers who have done the work and know what we're talking about and are here to help us. So I've known April for a really long time. She helped us out with multiple complicated mental health clients, and so we've known each other for a long time. In just a minute, I'm going to let April introduce herself, but we're going to give folks 3:01. We're going to give folks a few more minutes to get in here. And because we have enough people or too many people to do introductions, we're not doing introductions. And if you want to, you can introduce yourself on chat by saying where you're from, how long you've been doing guardianship, if you want to, but you don't have to. So that's up to you. As you know, Kate works herself like crazy to make sure that the CEs all get handled. So make sure you put your information in about your OPPG number, and she will make sure you get your CE. All right. So Julie, you want to introduce yourself?
Hi guys, I'm the Director of Business Operations here at AGED. Really, Kate's the one that helps do all the great support for the peer group, but I kind of help support her behind the scenes. So hi everybody.
Is Kate still on, or is she?
Yeah, she's on. I think she's just dealing with. There's Kate.
I'm here. Hi guys. Okay. It's Kate. If you get emails,
that's Kate
from me.
That's Kate, who does all the work for Facebook and peer and just loads and loads of stuff. All right, so Kate, since I'm in the car, I can't check for anybody who can't find the get in. So check Facebook and okay, good. I can't see anything. The phone is all I can handle here. Okay. All right. So it is 3:03. We're gonna wait maybe one more minute for folks to come, and then April's going to take over. Let's see. Anybody else is stuck out there? I'm on my way down or over to Tampa to present with Katina Williams, who does a 40-hour guardianship course. And we, at AGED, we are always trying to get in front of those new students before they can get themselves in trouble. So we like to go meet with them in person if we can, and then give them the 58M book and a bunch of stuff about peer support, so then when they become a guardian, they don't make some of the bad mistakes that those of us who've walked this path have made, like me. So, all right, 3:03. We're going to do just another minute, and then we're going to get rolling. If you guys are having any tech trouble, reach out to AGED's phone number, which is 407-682-4111. If you're having some kind of
ask for Joe. Joe will be able to help you.
Ask for Joe, the tech guy. Okay. All right. So I think we're going to get started. So again, I've known April for a very long time. She's helped us with some super complicated mental health clients, and that's how we know her. I asked for this presentation because when I first became a guardian, and someone would name some alphabet soup of a test, and they would say they scored 7 or 32 or 61. Had no context or reference. I had no medical background to know what did that mean. Is that good? Is that bad? And so what should I do with it? So of course, over the years, I learned most of them through osmosis, but it's not the same as knowing from the beginning. So I asked April if she could come on and give us a little bit of understanding, not from a medical point of view, not from a licensed social worker point of view, but from a lay person's point of view, so that when you have a ward that has a test result of one of these mental health tests, what does it mean? And most important, what should you do about it or with that information? So that's it. So April, would you like to give a quick introduction, tell everybody how you got to be here, and then take the wheel?
All right, I will. I'll do that. I will share my PowerPoint screen, but just to start with an introduction, I am an old social worker. I have been working in Central Florida for more than 30 years. I think it's close to 35 at this point. And I am a medical social worker. I was trained to work with children and families. I've worked in lots of settings, including home health. And then 15 years ago or so, I started a home visiting mental health company, Counseling Resource Services. And we have worked with Medicare, aged and disabled population, and eventually expanded to all adults, which is what the company is still doing. I retired from there in January. But I continue to be a great advocate for them. They're a great mental health company. We have lots of wonderful therapists on that team that are seeing people in person, in homes, through telehealth, in the office, in lots of different ways. So it's still a viable, wonderful company. And I'm really excited to get to talk about these screening tools because I also would hear from people, well, the PQH9 is this or that. And everybody looks at this very differently. So I'm going to go ahead and share my screen and get started. What I would say is please feel free to put questions in the chat or come off the mute and ask your question because I cannot necessarily see you. And so I will not know, I cannot necessarily see the chat. So work with us. And if you have questions, please let us know. So
April, the first clarity is the vast majority of this audience is professional and public guardians.
yes.
Their staff. We have brand new guardians that just got their OPPG registration last week, and then we got guardians on here with 35 years of experience. So that's your target audience.
Perfect. And I think we share a lot of, I've worked with guardians through the years. We share a lot of the same concerns. And the really big concern is we see something going on and we think these screenings are supposed to help. And oftentimes the screenings get done and they fall flat, right? Like there's what do we do next? Or we hear that there's a screening and we're told it means, well, everything looks okay when we know deep in our soul that it's not okay. And so that's what we're going to talk about because we need to make sure that it is that what we're using is measuring what we think it is. And that's what we're going to talk about. So our goal is to understand some of the common screening tools, to learn what they're designed to actually measure, and then just to interpret the basics of the score. And that's really high means this is a problem, low means this is not, or vice versa. And of course, they don't all go the same direction. If they did, it would be easy. Talk about some of the limitations and then what do we do next? And you all know what do we do next. So the important part of this is to understand that the scores, the screening, and I'm sorry, I'm just moving this because there we go. All right, so screenings influence big decisions, right? They influence your work, they influence your interactions, but when the screening tools don't make sense or we don't have a good understanding of them, we risk over-interpreting or under-interpreting, right? And what your role is, right? I mean, I love our guardians, right? It's always about balancing safety and autonomy. What's the least restrictive way we can provide this care for people? And it's so important. And for you to do that, you have to have the best information. And screening tools are one piece of information. It doesn't answer all the questions, right? But it is a tool that you can use to support a good care plan and support informed, compassionate care. So let's see. All right. So what screening is versus what a diagnosis is, and that's a really important part of this, right? So screenings screening tools are snapshots. And so I always, have you ever had a blood test that's come back and you're like, oh my God, this is the, and you think, I have to go get it. You have to get this blood test again and again and again, right? And you go back and the results are completely different because blood tests are a screening of maybe that donut you had that you shouldn't have had, or it's a snapshot of what's going on right now. And so it can predict things, it can suggest things, but it is a snapshot of a moment in time. And we know that that gives us information. It helps us be curious, but it is not the same as a diagnosis, which is that comprehensive evaluation. So I always like to think of all of these, even for me, when I am able to diagnose mental health conditions, the screening tools that I share, and I'm going to share a couple of them with you, really are just pieces of information, and they help me ask the right questions or recognize what might be going on. So the tools that we're going to talk about today, right? The first two we're going to talk about are about depression and anxiety, because we know depression and anxiety play a huge part in cognitive decline. And we know that it's bidirectional. We know that sometimes cognitive decline causes this, and sometimes this causes cognitive decline. So we'll talk a little bit about that. But in addition, we're looking at tools that look at memory, attention, language, cognitive functioning like planning and problem solving, decision making, orientation. So when I talk about orientation, I mean person, place, time, right? And so what's important to remember is that, and I love it, when we think about that week between Christmas and New Year, when some of us are in that stupor and we don't know, right? Sometimes when we have a retiree with no cognitive decline, they're not going to be able to find the day of the week because it doesn't matter to them. So orientation can often be to other things, right? We're also going to look at functional ADLs. What is this? What's happening to them, and how does this affect their ability to function in their own home? So I saw a couple of, are there questions that I need to answer? Nope.
Well, I have a comment, April, that, how many times what we saw of a client when we first met them in the hospital after whatever, the surgery, the trauma, the accident, the whatever, and they absolutely were not connected to anything because they're in a strange place. They've been sick. They've maybe been put under general anesthesia. They really have no connection to like reality, but they're actually, and then when we get them out of the hospital back to maybe their home setting or their ALF, and they start reconnecting fairly quickly. So it always helps me to remember that, like, I've had a hospital stay, and when I've had a hospital stay, I didn't have a clue what time it was, where I was, what day it was, what month it was, no idea. So I think we need to be cognizant of that, because what you see in that snapshot is a little dangerous, because if there's any belief that that's actually where their base level is, it's likely not. So I just, time and time again, I was super careful about it, especially if that's when the exam committee members ended up seeing them. Right. In that environment, it ends up becoming, not necessarily the most accurate of assessment.
So I am so glad that you said that. What anesthesia does to anyone, right? Plus the stress of a hospital stay, plus the stress of surgery or medical care on the body. So it's the next slide. So we'll talk about that, but that can change your cognitive ability. That clouds the system, and you can look like you have severe issues, right? And so again, right, it's a moment in time and has to really line up with other information. So the first tool I want to talk about is the PHQ-9, which is a depression screening. And most of us probably on here have had our doctors or our therapist give us this. This is not just for aging or disabled adults. This is for all adults. And the purpose is to look for symptoms of depression and severity. And so it's looking, do you have these things present? Mood issues, sleep issues, energy issues, appetite issues, even self-harm, suicidal ideation are included on this. And this is something that is used by mental health professionals on the regular. Most clients will have, if they're seeing a psychiatrist, they will have this multiple times a year. If they're seeing a therapist, they will have this multiple times a year. And their primary care doctor will use this at the annual visit, the first annual visit of every year. And if they're seeing a provider that doesn't do this, that's a problem. So I'll just put that out there, because this is actually part of health outcomes that are expected by Medicare. The PQH9 is part of that. So this really should be used at everything. It is something that can be filled out by the person. So that's the ideal way, is it's given to the person. And then it can be filled out by somebody with them by asking the questions. But and here it is. This is actually all the questions in the tool. And so again, you want a lower score means that there's less going on. Higher score means there's more going on, more indication. But let me say, for me, I can use this tool as part of diagnosing for a mental health condition, but not this tool alone. So there also has to be these symptoms plus impairment. It has to impair how they function. And you know what? Some people do fine feeling like they don't want to eat and are always tired, right? So again, it's information, but this one is really important. And it's one of those things that you want to make sure, because again, depression, particularly, research has told us, is bidirectional, that people who have cognitive decline are more likely to have symptoms of depression, but people who have long-term depression are more likely to have cognitive decline. So important to treat this. And here's the other thing. Even if somebody has dementia or has one of the dementias, and has these symptoms, treating these symptoms can make them function better. So this continues to be an important tool to use in the early stages of cognitive decline. All right, so the next one is the GAD-7, and that is an anxiety. So I cannot tell you how many people I have had who have said to me, I think I have cognitive decline. They say dementia. I think I have Alzheimer's. I think I have this. And it is anxiety. So what we know about anxiety is how it changes memories in the brain, because anxiety prevents the brain from encoding memories. So if the first indication to somebody is that I have cognitive decline because I can't remember anything, first thing I check out is, are you worrying? Are you anxious? Are you ruminating? Do you have thoughts going in your head that you cannot stop? And if the answer is yes, that's where I start, because you cannot get the information you need if you are constantly worried. And so it looks at irritability, worry, restlessness, sleep, muscle tension, but this is one of the biggest things that get confused with cognitive decline. And that is, and remember, as we work with aging population, anxiety is often distributed across lots of places, but when their life becomes smaller, the anxiety gets stuck on my health conditions, or what am I going to eat, right? That's
the very tiny little focus they have. Yeah.
It is. And so you'll get high levels of rumination, and you'll get high levels of, I don't know what's wrong, but I can feel the dread in my body. Well, that's stopping the brain from being able to use the prefrontal cortex, decision-making, thinking through things, and it's not encoding memories. So it's really important to look at anxiety when we're looking through these. All right. So, and you can see here, obviously, the smaller the score, the less symptoms. And these are actually just the 7 questions that they ask for this short screening. This is also one that's done by primary care. It's done by mental health providers, psychiatrists, psychologists. It's done by everybody who sees people on an ongoing basis. But this is something your primary care can and should be doing at that annual visit, and then on an ongoing basis if something comes up. All right, so I've already said all of this, so I won't spend a lot of time. Depression and anxiety look like cognitive decline. And so it's important, whether they actually are diagnosed with depression or not, that we consider treating this and making sure, because it can make life better if you do have cognitive decline and you are treated for these conditions, it can make life better. All right, so now let's talk about, I can stop there if you have any questions, if there's anything. Otherwise, we're going to talk about the mini mental status exam. This is another one. This is the most common. This is the one that I was taught in graduate school, and trust me, that was a long, long time ago. And so there have been many iterations of this. This is used for any adult, and it measures global cognitive functioning. And so it's looking at memory, it's looking at language, it's looking at orientation, it's looking at attention. And it is a 10-minute screener at most, right? If it goes longer than 10 minutes, then you're usually dealing with something. And so I put it on here. This is one where the lower the score, the more significant the symptomology is present. And so when you look at this, you can see what is the year, the season, the date. So you're just ticking these off, right? And like I said, people don't know. I had somebody I talked to Teresa about not too long ago. He could not tell me the day of the week. But when I first started working with him, he could tell me everything about the president, right? And so we could have a full-on conversation of he knew who the president was, and he could talk about politics, he could talk about things, but he couldn't tell me the day of the week ever. And so those kind of accommodations can be made in this tool. And so, you'll see here that one of the other things it says is 3 objects, right? You will say tree, pencil, ball, right? It's really important that we don't use the same, because this patient in particular, the first couple of years that I worked with him, he could say, okay, I know what the objects are, right? He would tell me before I ask, because people use the same one. Make sure you change this up. And so if a doctor is using this on an ongoing basis and you happen to see them, you might want to say, he remembers that. He can't remember what you just said, but he can remember, right? So we as providers have to remember that we do have to change this up. But it's very commonly used. Again, this is used in most annual evaluations. And if someone reports to the doctor, I think that there's some cognitive decline, this is the first thing they pull. Now, here's the problem. Yeah. If you are really smart, if you've done this many times before, this is not necessarily going to show anything. And I have one on here that does, so I'll talk a little bit about that. But this is kind of like the idea of having a hammer for everything, right? It's good and it works and it's important, and it's not the most nuanced one, but still very accessible, very important, and something that everybody uses. All right. Here is the more nuanced one, and I love it. And so I wanted to show you a picture of it. And this is the Montreal Cognitive Assessment, the MoCA, which just made me think, I want to have a MoCA drink today. I want some coffee and chocolate. So it detects early cognitive impairment. And so it's looking at executive function, memory, attention, and it is much more sensitive to change, to the subtle changes for the earlier changes. And so here's what's important to know. This is for your higher IQ people, your people with more education, your engineers, your people who are not going to be, who are going to be able to answer those things no matter what happens. And this is one. I had a client that I worked with who was, he was an engineer. He had made everything under the sun, right? Had patents on everything. He could ace the mini mental status exam, no problem. But right. He couldn't do basic things. He would miss things. He was clearly having cognitive decline, but it was a test and he could always pull out his best, right? And he was able to do that. And actually I've had lots of them. So I was so excited when I learned about this one, because it allows for higher IQ people to really assess their change. And like I said, it's more sensitive. The problem is it's going to have higher false positives, right? And so what that means is because it's so subtle and nuanced, you might have more, right, more false positives. But again, we're using it as a snapshot of information, a moment in time. Then that false positive isn't as important as being able to actually get a test that works for people with higher IQs.
So April, would you give a very short description of what executive function means? Just super short.
Yes, 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 yes. Okay. So executive functioning is your ability to plan and execute. So I had a doctor who described Alzheimer's to me, and please forgive me, this is such an oversimplification, but it talks about that. So I get out to my car and I don't have my keys to get in, and I shut down. That I've lost my cognitive function. If I go out to my car and I can't find my keys and I go, oh, let me go back in and look, and I go to the places where they were, right? That shows that I can problem solve. Oh, I might have left them here. I might have left them there. It's that ability to plan and execute something or to problem solve using planning and executing. I can go into a longer one, but I
No,
think
that's enough. That's
okay.
enough. Plan and execute is exactly what I wanted to hear. That helps me make sure I get it.
Yeah. So here's the other part of the test. I just thought it was, I love this test. So anyway, like you can see down at the bottom, right? 26 to 30 is within that normal range, normal, whatever that is. And then of course, 17 and under gives us a moderate to severe. And so really, if you have problems getting somebody, you know something's going on, and the many mental status doesn't get it, pull this one out. Get someone to use this one.
Okay.
This is the next one, and this is the slums. And I am so sorry for the name of this. It's the St. Louis University mental status, but what it identifies as mild neurocognitive disorders. It assesses memory, attention, executive function, same things. But this one actually is for lower IQ, lower education. And it adjusts for that. So you're not penalized in the testing for that. It's a good solid test. It's, average to below average IQ or lower education range. You get fewer false positives.
Okay.
And so this one has, just a lot of good, but I just don't like the word slums.
No, it's a terrible name. So April, would this be the one that you would use in the environment of someone who didn't know how to read, or who was, developmentally disabled as a younger person? Would that be the one typically?
This one would fit that, and it would fit, someone who doesn't have formal education, someone who doesn't have out of elementary school education, even middle school education. It would fit for all of those.
Okay.
And again, it's the higher the score, normal behavior or normal expectations, and the lower the score, the more symptoms of cognitive decline that they have. Okay, so we've reviewed mental health tools, we've reviewed the screening tools, and now we're going to look at staging tools. And so staging tools assume that cognitive decline is present. And what a staging tool does is it looks at how much this is impacting your life. Because again, that's an important piece of this, that a tool that just says to you, these symptoms are present, doesn't tell me the impact on life. And the impact on life is an important part of the diagnostic process, right? So this tells us that what difference does it make? And so this is a really lovely test. It's called the Clinical Dementia Rating, CDR, and it looks at the dementia severity, right? It rates where you are, and that's what staging is, which stage, right? It's also looking at memory, judgment, daily functioning, executive functioning, but it is interview based. And so it is all about a conversation. And the more words you put into an assessment, the less somebody can bluff their way through it. The more conversation you have, the more you find the limitations. And so I love this because the mini mental status is yes and no questions, right? Can you do this? Can you not? Can you do this? Can you not? When you get into an interview, right, which takes more time, you are looking for the nuances. You are looking for what do they do when they can't find something? Do they recognize that they can't remember something? Do they get frustrated? How do they respond? And so it's a lovely one, but it is interview based and it does take time to do it. And so I put this domain in so you could really see their scale. These are all of the domains that they look at: memory, orientation, judgment and problem solving, community affairs, home and hobbies, and personal care. And so
it's so much more realistic to what we really want to know.
Yes, yes, right. Because we can oftentimes know, and I know we all know this, but there are so many people who have cognitive decline that never get the full battery of testing to prove it because they're 92 years old. And the doctor says, why am I going to put you through this intrusive testing process if we just treat it as if it is? And good or bad, I'm not the doctor, I'm not going to judge it. I'm going to say it happens. I see it all the time. People have a cognitive decline, they have a dementia diagnosis, they have a vascular dementia diagnosis, and they've never had test one to no neurological, no process. And these tests particularly help with that, because what are they able to do, and what difference do these symptoms make in their life? This one is called the FAST. It's the Functional Assessment Staging Tool. So this is also a staging tool. It tracks functional, so ADLs. It looks at how the physical body or capacity of their ability to take care of themselves. And this is another fabulous tool because it's very practical, right? Are they able to feed themselves? Are they able to do the things that they need to do to be able to participate in their own care? So again, it assumes that cognitive decline has been identified as present, and it looks at what difference does that make in their life? How does that affect them directly? And where are they along the path? All right. And so this test is called the BLEST test, and it has another name, but it is the one I know the least about, that I learned about in here. This is actually hybrid. It's actually assessing symptoms and staging. And so what I read about it is it's actually really good, and it's going to be interview based, and it's going to be a very intimate exploration of what cognitive decline symptoms exist and how they're affecting the person. And honestly, when I asked some of my nurse practitioners and other providers, nobody had heard of this and nobody had used it.
So, okay, that's new.
And so I'm not saying nobody's using it, but I liked the hybrid approach. And I think sometimes people get their favorite test. I know this because I do it as well, and they don't go outside of that. And so they're really just looking for that ability to do what they always know and what they get answers for. So it impacts both the symptoms of cognitive decline that are present and the impact on functioning. So that is it for the tools that I plan to talk about. And so if there are any questions about that, I can answer those.
Okay, so let's give the guardians sort of, because you said some really good stuff that I didn't think about doing. You mentioned about how the PCP should be doing some of these tests annually, and I can tell you, plenty of them have never done it. So as you're talking, one of the things I wrote down was maybe we should, as guardians, treat this like we do vaccines or the flu shot, or kind of put it on our system as a list of, did you get a fast? Did you get a blessed? Did you get, in the last year, did you get an MOC, a MoCA? Did you get a CDR? And then to what end? Okay, that's the other big deal. So you got it, you got that. How is it going to help you provide better support and care for them? You talked about engineers. I don't know what it is. We've had a lot of Lockheed engineers as clients, and they are complicated because what happens is they don't lose their processing the same way someone of a lesser IQ does. I'm not a doctor, but I've seen it over and over again. And one of their problems is their aggravation with the caregivers, which is super high level. And it's usually because the caregivers don't have the IQ that the engineer has. And so there's not a working relationship there. So what I really want from these tests is which ones will then help us design better care situations, whether it's in an ALF, in a group home, with caregivers at home, will help us recognize where the deficits are, and then focus on getting support that relates to those deficits, not the other deficits. Like I've had my engineer guy, if that caregiver walked in there to brush his teeth, he would knock her out. He would be so angry. You think I need help brushing my teeth, young lady? And he would get really upset. But he could not manage to put the key in the door to open the doorknob. So very strange, because both of those are, all kinds of functioning. So what I'm looking for the guardians to get from this presentation is, so which of these would make the most sense for them to kind of make it consistently their tools in their toolbox? How do they know which one should be helpful to them?
So I think that it is really fair to expect that at every annual visit, the doctor does, right? Because, they have it's required by Medicare to do the PQH9, the GAD7, the GAD7, and a mini mental status exam. If you suspect cognitive decline and you have an engineer, I would take the MoCA with me. It's online, just print it off, take it with you, and have the doctor do it. Because the doctor is not likely going to have this have it at the office, because they use the mini mental status exam. And unless they specialize in working with this population, and even those that do, they don't necessarily depend on anything else other than the mini mental status exam. So that is, I would expect that annually. And then if you, like I said, if you're working with an engineer, or the slums, if you're working with someone who is lower functioning and the mini mental status always looks bad.
Yeah.
Right? But you're like, but they're higher functioning than what you're giving them credit for.
Yeah, absolutely.
There is no problem in printing any of these. In fact, if you want me to, I will email them all to you. I pulled them all up and downloaded them for this presentation because I wanted to play with them, because I haven't done some of them in a long, long time. So I'll send them to you. And
April, send them with your PowerPoint, and then Kate can share them with everybody, and they can, obviously we are not qualified to complete these tests. We've not been trained to do it. But the idea of carrying a blank one in a doctor's office, that is brilliant. Because then they're going to do, great.
Well,
great idea.
And that makes them aware. I mean, it's like always having flowers when you go to the hospital, because then they know somebody's watching, right? So, so there is that you can include these, and you can include them any time, and you can demand or ask that they do it. So the other side of that, which is your question about how do we make these make sense? I know that you do ADL screenings with people, right? Like, what are your skills?
I mean, all guardians do that constantly from a need of placement and care. Most of them many of them are in facilities, so some of these tools have been done by providers in the facility, but we all do them just from a common sense point of view to know, what can she do? It also, of course, has lots of benefits and lots of placement stuff. So yeah, it's not, plenty of guardians don't have an actual form that they complete that says ADLs or IDADLs, but many do. It depends on their style of work.
So actually, oddly enough, we have a question in the chat that deals with this very thing. So Diana wants to know, do you do any actual functioning assessments of watching the individual perform specific tasks in their home, like medications, simple cooking, toileting, dressing, ADLs like you're talking about? She said not all wards will allow themselves to be seen by a physician and a nurse practitioner. So do you do that stuff in the home?
So do I personally?
Yeah.
So I'm an old social worker. So that answer is yes. Does everyone? No. So, but you can, right? I mean, the idea is that I was in one of my clients' homes and she happened to get a rescreening for whatever. And they called and they said, "Are you able to cook for yourself?" They were asking her ADLs and she said yes. And I happened to be there and I said, no, she's not. She can make toast. And toast is not cooking for yourself. Toast is toast. And so it is important to have that eyes on to see what their ADLs, because how they perceive, right? And, there's a better than average syndrome, right? That we all have, right? We all have that. We think that we are doing better than we are. And so people will report themselves on their best day, not on their everyday. And so that, yeah. And so that is part of, so this goes back to the training, not necessarily of the guardians, but of the people who are providing service, which becomes that question of, what do you feel like doing today? Right. So if somebody's irritable and cranky about brushing their teeth, then the question becomes, what do you feel up to doing? Just like you do with your kids. Do you want to put on red pajamas or blue pajamas? You're still giving choices. What do you feel up to today? Right. And so as the guardians, that's part of what you advocate with people who may not understand this, who are looking to function in a specific job. They're checking off all the lists instead of promoting the autonomy of the individual, because some days people can brush their teeth and some days people don't want to brush their teeth.
Don't want to, right? There's a whole other thing. So this is an interesting situation that many guardians have an outing with their ward a couple times a year, whether it's to a meal or to a shopping thing. And I always tell them it's one of the best assessment days you'll ever have, because they are not sitting in that chair in that ALF. They are being exposed to a world of stimulation of things happening. How they addressed the waitress if they ordered their food, how they dealt with the menu if they could read it. And I like going on outings with the client because then I get a much better feeling of what they choose not to do in the facility, but what in public they will happily do. Like, one of the funny things I find with a lot of folks is if you take them to a restaurant, they will fight you to pay the bill. And that's generational.
It is.
And that's who they were 40, 50, 60 years ago. And that's still there in them. Yes. And so I like that, because sometimes I forget in the facility, the stimulus is low, the engagement is low, the new, unique, different stuff is low. And so maybe they just don't care enough to show that they can do the thing. So I like clients go on outings. And April, this is funny. You wouldn't know this necessarily, but guardians get in trouble for billing for going on a ward's birthday, because I know, listen, we put up with crazy stuff. But anyway, the courts will say, well, you shouldn't get paid for going out to lunch with them on the birthday. Okay, fair. So I tell the guardians, your billing does not refer to the fact that it is their birthday. Your billing refers to the fact that you took them in a unique environment to see how their ADLs have improved or changed. And you don't talk about the birthday lunch. Yes, you did have a birthday lunch with them, and yes, you did get them a cake. But the courts don't need to know the cake. They need to know what you were actually doing as part of your guardianship job. And over the years, I found many times that I was kind of, I shouldn't use the word giving up, but I was believing that a client was much worse than they were, and taking them out into something that they're interested in showed me the difference.
It is so important to have those eyes-on experiences. I remember, I mean, my grandmother has passed away, but she had Alzheimer's, and she had declined for a long time. She was very healthy and had the mental decline for almost 17 years. And so we saw her in so many different situations. And every time I would get to see her and we would go out, I watched that progression of symptoms. So it is so important. But the question being, doctors aren't going to do it. Doctors aren't going to do it. There are sometimes if you work with a home health company because they've had an issue, you can have the social worker there watching. You can ask the nurses there. There are ways to get the information, but it's not easily accessible. It is a lot about self-reporting, and we know that that can be very unreliable. But again, that's for later stages. So just regarding these, right? Just remember, these screenings are a snapshot in time. They can be affected by the time of day, by mood, stress, anxiety. If we have somebody who's having later day issues, make sure their appointment is during later days, later part of the day. Otherwise, they show up and they look like they're okay. Time of day matters. Medical, did they sleep? Did they take meds? Did they not take meds? Just, the limitations of these screening tools are affected by all of these things.
Well, that's one of the problems in guardianship. So what happens is the 3 examining committee members see the client at 4:45 in the afternoon. That's going to be a full-on sundowning. And then every once in a while, you get a lucky break and you get 3 examining committee members that come at 3 different times, 9 o'clock in the morning, noon, and 4:30. And you get 3 very different answers, which is actually accurate. That's actually what really did happen. And so like as a guardian, I'm always telling guardians, before you accept a case, there may be circumstances where you should go see that potential client yourself in person at a couple times of the day. Because if you go at 4:30 or 5, you're probably going to see the real tough times. And then if you go at 9:15, 9:30 in the morning, they may be pretty okay. And now you get an idea. So Kathy Bowers is asking an interesting question. She says, can you share the Medicare link where the 3 tests that you've mentioned should be done during an annual wellness or visit to the PCP? Is that something you can share, April?
Oh, okay.
That's going to be some digging.
Yeah, let me work on it and see if I can get it. It's all about those standard health outcomes that they enacted quite a while ago. And so let me see what I can find. I'll take a look, but that's going to take me a little bit because it's been a long time since I had to look that up.
Okay. All right. That's awesome. So the other thing, going back to what to do. Okay. So the guardian gets a new client and they have a score from wherever they were, the ER, maybe it was at home, maybe it was with Adult Protective Service involved, maybe it was wherever. And their gut, which is a lot of what guardianship is actually about, honestly, I think if I had to say, what is it you actually work with as a guardian? Your gut. So if your gut was saying, I don't really think that the score that she got on whichever, the MoCA, whichever test, I don't really feel like it is relevant because it was under bad circumstances. So, we've got the cost issue. We've got the putting the client through more trouble. I want to talk again about to what end. So we get a new test to do what? What are we actually trying to accomplish with getting those new results?
So that was part of some of the slides that I've put in here. Oftentimes, right, we get these results and they're inconsistent with our own experience. right? Like, that's not how I see this person. Maybe there's some sundowners and they're not performing, but they can do 70% of what they need to do to function every day. It's only about 30% they need care, right? I always encourage people to slow down, right? Like, just slow down, take pause, take a breath. Don't try to implement that. Set up another doctor's appointment and have them set it up in the morning if the last appointment was in the afternoon. Or, if adult protective services have been out, that can feel very anxiety provoking.
That's a very panic situation.
And that is and so I don't want to say I wouldn't trust that. I would say that I want to confirm that that was the most accurate. And so
Okay.
I'd get them, the medical group, to do it.
Okay.
I'd say, I just want another health screening, and please, in this health screening, use, and just ask for the mini mental status and ask for a copy of it. May I have a copy of that? Right? Some of them have it on their screen that they do it, but there's a piece where they have to actually manipulate. And so they should be giving you a piece of paper. So you can ask for a copy of it.
Okay. So the other practical thing that I want to ask is, when ALF is pushing us to move a client into the memory unit, and we really don't like it and we really don't want it, do you feel like these tools might be somewhat helpful in the way of saying they are old? Well, two things. One is they want to push them to go in the memory unit, and two is they want to increase their level of care up another $1,500 or $2,000 a month.
Right.
So I kind of wonder, would any of these kind of give me defense to that? Maybe a little bit?
Absolutely. Absolutely.
Okay.
Because remember that it is about, we know it, it's about money and ease, right? If somebody's behind a locked door, they don't have to guard them as much, and it's going to cost more money, so they're getting more resources. So it's perfectly appropriate to ask for, if you want that next level of care, then we need the medical proof that that's necessary, right?
Okay, I like that.
You can say, let's take them to the primary care and have them do a screening, not the ALF, not the person on site at the ALF.
No, not their staff. No.
But so many of them talk you into using the doctor on site, and it's perfectly okay. You can have two primary care physicians, and it's okay to say, no, we're going to go back to this doctor who knew him or her and let them do it. We're going to have a consult that way, or we're going to try a new provider. But going back to someone the patient feels comfortable with is really important, and having that outside party, and consider who this is and have them do the PQH9 and maybe a MoCA, because they're, because they're high functioning, or the slums because they always test poorly and it's because they have a lower IQ. Be very selective in that. And to come back to that, and I think it's very fair to ask for a medical reason for that, not just because they got lost or they got,
Right, because it's the facility's convenience that becomes the whole thing. And so, I mean, and I'm not saying that they're never right, but sometimes I feel like, listen, you guys are just, there was one situation where he was a little bit difficult. That's not enough. So I really want a way to try to say, okay, let's come up with something a little bit more concrete about why this is not fair. So I like that a lot. Okay.
Well, and it's like kicking them out for having hallucinations during UTI time. Well, control the UTI, you don't get the hallucination. It's the same idea, right? That people are super depressed, they're going to have hallucinations, and they're going to want a higher level of care. And so that is what the benefit of having guardians is. You're always focused on autonomy and least control of the patient, giving them their ability to care.
Yeah, in guardianship, our two standards are least restrictive and self, and their own
self-determination.
No, I'm saying incorrect. They are, oh my gosh, I just blanked. Our standards are, okay, now my dementia is showing. Hold on a second. The way you say best interest, there we go. The two standards are best interest And what's the other one, guys? I'm drawing a complete blank. Oh my gosh. Best interest versus what they choose for themselves. Gosh, anyway.
Substituted judgment, is that what you're looking
Thank
for?
you. Yeah, thank you. Best interest versus substitute judgment. Thanks, Julie. My dementia showing. You know, everybody always talks about that one, and when you want to explain it to somebody, I always use the cigarette story of the 96-year-old guy that's been smoking since he was 20. No, I'm not going to take away his cigarettes. Yes, would it be the best interest for him to stop smoking Camel unfiltered? Sure. Am I doing that? No. We're 80 some years into this. All right, Marilyn Young has an interesting question. She says, even if you have the ward retested, the first diagnosis, i.e. severe dementia, will not be removed from the record, even though it is maybe not correct. So is the retest just for our working relationships? Ooh, talk about that, April.
Okay, so it's not a diagnosis if they've only used screenings.
Okay.
So if they've only used screenings and the doctor has diagnosed based on a screening, you've got grounds to ask for, what was the diagnostic protocol that you use to come up with this diagnosis? Because all I see is a mini mental status exam and some reports about behavior. So if it's inconsistent with what you're seeing, then it's okay to say, we need an actual diagnostic evaluation, right? And so if somebody gets diagnosed with actual dementia, and it turns out they were having a reaction to a medication that it made it look like this, or their family was manipulating and got all this done, and then they ended up in your care. It is, you do have to resubmit for an evaluation, and you do oftentimes have to go to court for it. And I know you all know that.
Well, no, but that evaluation has more to do with capacity versus the evaluation, because nowadays I feel like I really want a more defined dementia flavor, because I want to know if we're talking about vascular, or we're talking about alcohol dementia basically, or we're talking about Lewy body. I really want to kind of have an idea if we can, because that has a lot to do with what I am facing down the road with their care and what they may, with a lot of these frontal lobe clients, they are completely losing the ability to speak, and they don't lose anything else. They don't lose a single other thing but the ability to speak, which is just torture. Well, if we see that's coming, and especially fast with frontal lobe, which is exceedingly fast,
Yes.
I want to be in front of that 8-ball, not behind it, and try to have some tools or maybe a special kind of little computer or some things that can help them continue to communicate for some period of time, because otherwise it's bad stuff. And we had a client recently that from one Thanksgiving to the next, 1 year, he went from being very communicative, writing, reading, speaking, to almost nonverbal. 1 year, fast.
So I had a patient who had vascular dementia, but they just called it dementia. And she was having hallucinations, and she was having all of these issues, and they never put it together that it was vascular dementia. And if they controlled for the vascular issues, right, when they finally got that regulated, she was worlds better for a long period of time. And
so then I really want to focus so much on what you said before. So to Marilyn's question, these are not diagnostic tests. These are screening tests. And that's really good words for me to hear again in my brain, so that I don't say this is going to diagnose something. This is going to screen. The next level is a proper diagnostic evaluation if we need that.
If you need it. And so that is the question, is what testing was done to generate this diagnosis?
So Marilyn did chime in, and she said that they were diagnosed incorrectly because their words were not understood by the tester.
Yeah.
Good.
Well,
and then Diana also chimed in and just said, I'm part of why you guys were talking, that a neurocognitive psych eval would be more appropriate in certain situations.
Absolutely. So a neurocognitive psych eval, right? I mean, the whole idea of getting the dementia, and I think I've put it on here. I don't know if I give you enough information, but it's not just, it's to a neurologist. It's to it can be to a mental health assessment as well. So you're doing a neurology assessment. You may see a psychiatrist. Depending on what the symptoms look like, it is not just one test, which is why you don't want to do it for everybody, because it can be quite expensive and intrusive.
Right.
It is certainly worth asking, what was the cause of this? Why? And so if you are suspecting, get the psychologist notes, get the psychologist who did the neuro test, ask for their notes so that you can see what happened. You may have to become a detective, which you already do, right? You may have to look at that. And I'll tell you, I've done that. I've gotten a psychologist test and I've read it and I've said, who did you even interview? Because this is not my patient. And so I have, if it doesn't sit with you, ask for another one. You have the right to advocate for them to ask for another test, ask for a different provider, to say,
Right.
this is too inconsistent with what I have seen. They're not perfect.
Right.
People have bad days and people, write over other people's, right? The psychologist who's doing the test is writing over a template that may have somebody else's information and maybe they've made a mistake. They're not perfect.
Right. Right.
So
Right.
Ron has a question. He wants to know, what types of mistreatment have you witnessed as a result of bad screening?
Oh, it is about restricting. We have one way of treating people. And I had a patient who, again, he's the patient who I spoke to Teresa about recently, who was not hard of hearing. And he moved into a facility, and that was part of the work that I did with him, and it was 10 years ago. He was never hard of hearing. He died not hard of hearing, and everyone spoke to him at the top of their lungs, and he would look at
Oh
me,
Lord, that's like being yelled at. Oh
and that's what he
Lord.
would say. He would say, "What is wrong with them?" And I would let everybody know he's not hard of hearing. But that's continually, it's when we talk about mistreatment, it's really about not asking the question. And so that we limit people's dignity. We don't, right? Like the question of the brushing your teeth. It's got to be, let's get curious. Let's not just try to get through our job, but to say, what are you up for doing today? What do you need? And that's where I see poor diagnosis, inconsistent diagnosis, right? Sometimes it limits people getting the care they need because the doctor is so convinced there's nothing wrong with the patient that they see this much and I see this much that they don't, so they underdiagnose. They, the screening doesn't show enough for them to believe that anything else needs to happen. And so we've got to wait until something bigger happens. And so that's mistreatment, or they're in places where they're just assumed not to have any autonomy and not to be able to make their own decisions.
I mean, I always feel like putting somebody in a memory unit is one of my very hardest things to do, because when I'm in that memory unit and I'm looking around and not a single person other than the staff can actually have a conversation with my ward. They simply can't. So if my ward is like the smartest guy in the room, that's the last place you want to be in a memory unit. You want to be the dumbest guy in the room. That's better because, and so moving somebody into a memory unit to me always feels like a failure on my part as the guardian, because that's where things go bad and not happy, and they lose what little bit of connection they have to the world. So right. I love the idea of using this as a tool if I feel like the facility is pushing for a memory unit when I don't really feel like they're ready for it, because I don't want to go. Sooner is not, sooner may be better in hospice, but sooner is not better in memory units. So that's my perspective.
Yeah. No, 100%. It's
yeah.
Yeah.
Okay.
And I will say again, screen for anxiety and depression too, because that beginning of, let's get them to memory care really may be about depression and anxiety, right? And it could be about hearing. I mean, we all know that, right? I mean,
right.
Sometimes it's subtle. We don't realize people are not hearing, and that really disconnects you, which then can look like depression, which then can lead to cognitive decline. So,
right. So April, the one thing I want to understand is, how is grief as a thing separated from depression and anxiety. Just personally, Nick and I lost a child in 2019. And the perspective that when I would go to my medical providers for medical care, they would refer to me as being depressed. And I'm like, do you understand that I just lost a child? Do you get it? So is there a screening for grief that separates the grief from the depression kind of thing? Because for me personally, it made me recognize a failure in the system that from a medical point of view, I'm sure I met the criteria for depression. I'm 100% sure I did. But it was grief creating all those symptoms. So is there like a screening tool or a thing for grief? Does that exist?
So that's so fabulous. And I am sorry. I'm sorry for your loss. And what I will say is that when I said back on the diagnostic, when we were talking about depression, that's why just the screener alone is not it. Because I have to say, is this situational? Is this about something, right? Because if it makes sense, right? Oh, well, I have all these things because I had a loss.
Right.
And actually, grief, as we know, is the brain's way of teaching you to be able to deal with what the loss looks like. So you actually have to feel these things. It's really important to go through all of the stages of grief.
The loss.
Right. So it's necessary. So you have to feel bad, and you have to feel bad for a while.
Right.
And so,
and see, in guardianship, it is grief.
Yeah.
They've lost their friggin' rights. This is not a play game here. And so sometimes when I feel like saying, I'm not sure we should be using the label depression for a ward who is pretty high functioning, but lost their right to drive, their right to work, their right to vote. That's a big deal. And those are losses. So I want to make sure we think about that when we're talking about this, because you know, just because they have some form of dementia does not mean they cannot grow through the grief process. Does not mean that. And I want to be good at recognizing plenty of clients don't feel grief from the loss, from the guardianship. They do not. It's not where they are. But I think plenty do.
Yeah. So there are grief screeners. I'll look and see if I can find one that I think applies to this. There are, because they look for complicated grief when you get stuck in your process, and so that you don't. You know, because grief is never about getting over, it's getting used to, right? It's that process. And so I'll look and see, but I do want to say that I don't have a problem about being calling grief depression, because I think, you know, except for everybody wants to pathologize everything, but I think I'm having, you know, postpartum, you know, this depression after, you know, this, or, you know, I get sad when I get back from a vacation and I have days of stupor where I feel like, oh, what am I, you know, we all have that built into our system for different things. And so if we begin to just acknowledge and say, you are really grieving the loss of your ability to drive. And that,
oh my God, just to say those words to somebody would have so much value, because they would say, okay, first of all, you're recognizing that I lost something. And then, of course, the problem is in a guardianship, we're often the target of their fury that they lost their right to drive, even though we didn't take it away from them. And so I've had that very conversation, especially with gentlemen, that very conversation with them and saying, I think you're really frustrated and sad about not being able to drive. Am I right about that? And then we get the whole conversation about it. And then what can we do? Like with one of our clients, quite frankly, we got him a golf cart. Because none of us believed that he couldn't actually manage, and he lived in the right community where there was no big streets and it was relatively safe. And he was quite happy with that. Now, my other driving story is the client that Julie knows. Back in the day, he lost his license and got so mad, he went to Home Depot and bought a riding lawnmower and drove it down 436 to tell us all to go pack sand. So, yeah, there you go.
Well, and I had one that kept his van but disconnected, so he couldn't drive it. So he would go sit in it, but he couldn't drive anywhere. And that
which
was
is okay.
But it
Yeah.
is about that discussion around, and it can feel like depression. It can
Yeah.
feel like you feel hopeless and you can feel this and
Yeah.
that. So I will look for a grief, but I think it's
I
okay.
just would like to know better what to understand, because I know for what I went through personally, it made me much better, much more comforted when someone said to me, I can't imagine the grief you're going through, versus I think you're really depressed. For some reason that pissed me off. I don't know why it did, but it did, because I was saying, there's one trick pony that caused this. This does not come under, this does not come under the category of a neurological disorder. I am in deep grief. So, or maybe
and
it
it's
is a neurological
normal,
disorder.
and it's normal, and that's why it feels so bad. You're being minimized as a mental health condition when it's really an appropriate response to an
Right.
experience, right?
Right. And see, when a ward has an appropriate response to the loss of their driving, or having someone become their guardian and becoming over them, which is quite frankly obnoxious, that someone's going to take over your life. It's not funny. And so I kind of, that will make me feel a little bit more like I have a better tool in my bucket, April, so that I can say, okay, and also to have the conversation with them, to remind myself to have the conversation with them that says, I think you might feel a little bit of grief of the loss, and you don't like this guardianship, and you don't like the loss of control. And that is completely normal.
Yeah. Normal and okay. And it's okay for you to be mad. It's okay. Right.
Yeah. Yeah.
Giving people back that choice, right? Yeah. Is really
okay.
good.
All right. Well, we are doing good, and we've got lots of comments, April, of a lot of people saying really good stuff. One person just said the cutest comment. They said, "This is gold. Excellent, very useful, great information, great presentation. April, you're a 10 plus, extremely helpful. Thank you, thank you, thank you." So good. So I knew that you would be this fantastic speaker for this, and I'm very glad you volunteered your time for us. So
yes, happy to do that.
All right, so it's about 4:11. If there's anything else we need to bring up or talk about, everybody said thank you. It was very helpful for me. Thank you, thank you. Julie or Kate, or Julie, is there anything we need to address, or are we pretty good?
No, I think we're pretty good. Marilyn did give us the end of her story, which was she asked for another test for her client, but it was canceled, but she canceled it. And she was pretty sure they would not remove the former diagnosis. The good news is she's in charge, and she's the healthcare surrogate in the POA, and she knows that her client doesn't have severe dementia, like they're saying.
Good.
So
Perfect. So
and Diana's saying too, we also need to realize that when the depressed feelings are ongoing, we really do need to look at clinical depression.
Right. So what we normally do, guys, and Kate's not here, but the short version is she gets the slideshow, of course, from April, and then now April's going to work on some other stuff for us, and then Kate sends that stuff out and works on your CEs. So it won't happen in the next day or two, but she will get it done within about a week usually. Okay. All right. Well, April, thank you so much. I feel like I have a little bit more clarity, and I hope everybody who came and was here today has more clarity. And we really appreciate it. And I think we're good for today.
Great. Thank you so much for having me. I will send my information. I saw somebody asked how to contact me. I certainly do have some contact, and I'll put counseling resource services information in the slides and send them along with all of the tests.
Okay, that's perfect. Okay. All right. Bye, everybody. Thank you. Thank you so much, April. Really appreciate it.
Bye.
Bye-bye.